Ladies and gentlemen, I think people are going to join us, but we will start and have the ball rolling. So we start with community ophthalmology, and we have Professor Praveen Vashisht, Professor of Community Ophthalmology from All India Institute of Medical Sciences, Dr. Rajendra Prasad Center for Ophthalmic Sciences. He has done extensive work in the national plan, epidemiology, and several things. Udar?
So nobody is more qualified to speak on National Program for Control of Blindness than Dr. Praveen Vashisht. He's been the Sutradhar for the program for a long time and has the latest survey on blindness in the country to his credit. So we look forward to his talk.
आगे की लाइट्स कम कर दो, फ्रंट की ये जो आपके हाथ में नहीं है.
May I start? Yeah. Thank you. I've been given responsibility to present about National Program for Control of Blindness. I'll be discussing the, like as sir has said, the initial survey which has been conducted by NPCB. Some of the results will be shared. Then some initiative related to trachoma surveys and key activities of National Program for Control of Blindness. I believe most of you are aware that India was the first country to launch National Program for Control of Blindness way back in 1976. And at that time, the target was kept that will reduce the prevalence of blindness to less than 0.3% by the year 2000. Unfortunately, that target was not achieved, so it was extended to the year 2020. To show the what program has evolved, in 1971 to 74, ICMR conducted survey on blindness. That was the first national survey, and at that time prevalence of blindness was 1.38%. As a midterm evaluation 1986-89, the government of India conducted another survey, and what we found that instead of reduction in the prevalence of blindness, it was increased to 1.49%. Then there are some massive efforts by government of India. WHO, they started a program in India. There's a World Bank program for cataract surgical coverage. And finally in 2001, we achieved 1.1 as the prevalence of blindness. Another survey in 2007, it was 1%. But in all these surveys, the definition of blindness which was taken as, it is the presenting visual acuity less than 6 by 60. But in 2017, the government of India, they changed their definition of blindness, and instead of 6 by 60, it was changed to a cutoff level of 3 by 60. So presenting visual acuity less than 3 by 60. Another important change in the name of the program, previously it was just NPCB, National Program for Control of Blindness, but WHO took an initiative that we should give emphasis to visual impairment. So the name of the program was changed into National Program for Control of Blindness and Visual Impairment. All of you are expected to know the definition of blindness. So as per NPCB as well as per WHO, blindness is defined as visual acuity less than 3 by 60 in the better eye, less than 3 by 60. And in both the condition, it is the presenting vision, not the best corrected vision. So presenting visual acuity less than 3 by 60 is blindness, whereas the visual impairment has been divided into three components: mild visual impairment, moderate visual impairment, severe visual impairments. Nowadays, WHO don't use the term low vision. They just talk about mild, moderate, and severe visual impairment. Mild is less than 6 by 12 to 6 by 18. Moderate is less than 6 by 18 to 6 by 60. And severe is less than 6 by 60 to 3 by 60. Let's try to remember this definition of visual impairment. Overall visual impairment has been taken as presenting visual acuity less than 6 by 18. I just want to emphasize the fact that blindness is also a component of visual impairment. So all people less than 6 by 18 has been taken as visually impaired. And WHO in 2013, they actually started this program that by the year 2019, all the countries, they should be able to reduce the avoidable blindness, avoidable visual impairment by 25% by the year 2019, and a baseline was taken for 2010. That means in 2010, WHO gave figures for blindness and visual impairment for all the countries, and it was expected that they will reduce it by 25% by the year which has gone last year, 2019. So Government of India conducted surveys, that is National Blindness Survey, Blindness and Visual Impairment Survey. It took nearly 4 years to conduct this survey, and just to know whether we are at right track, whether we have achieved these targets or not. The report of this survey was released by Health Minister of India on World Sight Day this year, in October 2019. I'm glad to say that I was principal investigator for this survey, and this survey was conducted all over the country in 31 districts. And the key objective of this survey was to assess the prevalence of blindness and visual impairment, along with the avoidable cause of blindness and visual impairment, plus cataract being the major cause of blindness in our country. So one of the aim was to assess the cataract surgical coverage in country, as well as cataract surgical outcome in our country. Plus, if the people are not going for surgeries, also to assess what are the various reasons for barriers for cataract surgeries. The survey was conducted as per the internationally certified method that is called RAB methodology, Rapid Assessment of Avoidable Blindness, certified by WHO. It was initially developed by ICH. I'm glad to say that in fact the RAB methodology was initially started in India way back in 1994. Professor Hans Zimber was the then India representative in India, and he started this methodology in India. Now we've used version 6 of this survey. The advantage of this survey methodology is rapid, and the software is there. It can analyze data immediately after data entry. As I mentioned, survey was conducted in 31 districts representing 24 states. We covered 93,000 population for this survey in 50 plus age group, another 18,000 in 0 to 49 age group. So overall, 1,11,000 people were covered, representing 24 states. As a result, in 50 plus population, these are the figures. The prevalence of blindness was 1.99%, and prevalence of visual impairment was 13.76%. These are the latest results for our country, but these are the results in 50 plus population. Government of India asked us to extrapolate the result for the entire population. So we did survey in 0 to 49 to assess the proportion of blindness in 0 to 49, and finally we got the result for our country. The prevalence of blindness in overall population is 0.36%. So government was saying 1% 2007, now it is 0.36%, and the visual impairment is 2.55%. All the PGs, people are expected to know these figures, that we have approached quite near to the target. Target was less than 0.3, though it is not yet achieved, but we are quite near to these targets, and this is 2.55 is a visual impairment. Probably this slide is most important slide, and these are the estimates for our country in 2010 by WHO. 5.3% visual impairment and 0.68% blindness. This is less than 3 by 60, this is less than 6 by 18. And what we achieved is 2.55% and 0.36%. So it is 51.9% reduction in visual impairment, another 47.3% reduction in blindness. Probably I can tell against the target of 25%, we achieved more than 50% for our country. This is something a remarkable achievement, and our figures are at present close to the international, the countries which have considered as very near to those targets of achieving the elimination of blindness and visual impairment. But one important aspect, even after reducing leading to that level, the proportion of blindness due to cataract, which is avoidable cause of blindness, it is still 66%. 66% of blindness is due to cataract, and the second leading cause of blindness in our country is non-trachomatous corneal opacity, which is responsible for 7.4% of blindness. The other important cause is other posterior segment disease, and just see this cataract surgical complications. Cataract and cataract surgical complications are still the leading cause of blindness. This is really pathetic because both the things are very much avoidable cause of blindness. Now, cataract surgical coverage, that represents proportion of cataract surgeries conducted divided by the cataract surgeries required. And these are calculated based on various cutoff. Surgeries among blind, surgeries among severe visually impaired and surgery among visually impaired. Just see, nearly 93.2% is cataract surgical coverage. 93.2% blind people are being operated. What I want to emphasize, sir, that these remaining 7% which are not operated, they are responsible for 66% of blindness in our country. As far as the surgeries are concerned, nearly 60% surgeries are operated as being done in NGO and private sector, 40% government sector. 94% surgeries are IOL surgeries. One aspect about the quality of surgery in our country in relation to visual outcomes. 57.8% surgeries, they have visual outcome better than 6 by 8, 12. And just 17% less than between 6 by 12 to 6 by 18. If you add on together, 76% surgeries, they have visual outcome better than 6 by 18 and 10.9% worse than 6 by 60. When I compare these targets with the WHO goals, they said more than 95% IOL operation, we are reaching this target, but less than 6 by 60 should be less than 5%. And in our case, it is 10%. Better than 6 by 18 should be 90%, and we just have 75%. So the thing is very clear. As a result of this national blindness survey, we have to give emphasis to cataract surgeries, the quality of cataract surgeries, where we are way behind as per the international guidelines. We assess the reason for these poor and borderline outcomes. Among the reason, one of the important aspect is the other ocular comorbidities are there, which are responsible for poor vision. Beside this, there are operative complications. Nearly 1/3 of complications are the operative complications, refractive errors, and long-term complication is PCO is another one. Based on the National Blindness Survey, we emphasize that these are the disease where we need to give emphasis in our country: cataract, refractive low vision, corneal blindness, including trachoma, glaucoma, and diabetic retinopathy. These are the key objectives of our national program: to reduce the backlog. That directly means give more emphasis on cataract surgeries, so the cataract blindness can be avoided. Developing eye care facilities as infrastructure development, human resource development in terms of ophthalmologists and optometrists for their training, quality of cataract and other surgeries, involving voluntary sectors along with private sector in the program, and community awareness. This is for the PGs. I think this is very important. What are the national targets for various disease? For cataract surgeries, we have target of nearly 66 lakh surgeries per year, 200 lakh surgeries in 3 years from 2017 to 20. For other disease, it is 8.72 lakhs. For school children, it's another important program, provision of spectacles for school children, 28 lakh spectacles to be provided free of cost in 3 years. For presbyopia, 7 lakh is the target. And for corneal blindness, donation of the cornea donation, 1.75 lakhs, this is the target. For cataract, as per you can see, these are the achievement by NPCB against the target of 66 or 67 lakh surgeries per year. We are achieving close to these targets. The cataract surgical rate in our country is 5,000 surgeries per million population, which seems to be very good. But when we assess the need of cataract surgeries in our country based on the recent National Blindness Survey, it is estimated that we actually need nearly 2 crore surgeries per year if we need to eliminate cataract blindness by the year 2025. 2 crore surgeries per year, and I believe this is a very, very difficult target. Among refractive error, myopia is a key reason, lead cause for visual impairment among school children. This is one of the study conducted in Delhi. The prevalence of myopia in school children is around 13%, and you can see it is much higher in higher age group. In 11 to 13, it is 15%, and it is higher in private school rather than government school. 17% is the prevalence of myopia in private school. So the Government of India promotes school vision screening program. This is 6x9 optotype, single optotype is being used in schools, where we are supposed to do screening for school children. And as an achievement of the program, out of the target of 9 lakh spectacles to be distributed every year, we are going quite close to this one. But as per our estimate, the need-based targets are 60 lakh spectacles per year instead of just 9 lakh spectacles per year. For corneal blindness, we had a target of 55,000 cornea to be calculated as per NPCB, and we have achieved this quite well. It is nearly 68,000 corneas are being collected every year. I would like to emphasize about some work on trachoma. Trachoma is one disease which was a major public health problem in 1950s. In fact, in the northwest region, in Punjab, Haryana, Rajasthan, and Gujarat, more than 50% children they have active disease in 1950s. And Government of India started national program, not as national program for control of blindness, it was national program for control of trachoma in 1963. Currently, the WHO has a target that among the children, the prevalence of active infection should be less than 5%, less than 5%. And for adults, that in 15-year and above population, the trichomatous trachiasis, which is unknown to the health system, should be less than 0.2%. These are the targets by WHO, and they advocate safe strategy. We conducted survey for trachoma as part of NPCB from 2014 to 17, and as per this survey, the prevalence of active infection was just 0.7% in our country. WHO target was, we can say it is eliminated when it is less than 5%. So what I want to say is that, though we declared it in 2015-16, but actually it was eliminated way back in 1990s, but we never had the documentary proof for this thing. So Government of India declared that trachoma among children is being eliminated, and was done in 2017 by Health Minister of India. But as far as the trachoma among adults, that is the sequelae of trachoma is concerned, they are still higher, and it was estimated as 3.5 per thousand in this survey. As I mentioned, our target for elimination is less than 2 per thousand. So we need to work in this direction. So we had multiple meetings with WHO Geneva team, WHO CRO team, and WHO India team also, along with NPCB and RP Center. And ultimately, these monitoring committees were identified for elimination trachoma. Now the surveillance is going on all over the country. All over the country, in all the districts, they are reporting for trachoma. 200 districts in country have been identified as previously hyper-endemic districts. So special program have been started in these 10 states and 200 districts. All the ophthalmologists are being trained to identify and treat trachoma, so that we can say that trachoma is eliminated in our country. And in fact, I would like to emphasize that after conducting these surgeries, the team from RP Center, they will be doing surveys in all these 200 districts to assess whether trachoma is actually eliminated or not. And then finally, we'll be submitting a dossier to Government of India and to WHO to assess whether the WHO can declare that trachoma is eliminated. And we're hoping that by the end of 2021, we will be eliminating trachoma completely from our country. Sir, I have some time, 2-3 minutes? Thank you, sir. Something about eye care infrastructure. It is expected that as part of the infrastructure, at the top level we have Center of Excellence, which is called Regional Institute of Ophthalmology. The 20 are being recommended, 20 such centers. Then training center or medical college, where training for ophthalmologists and optometrists should be there. That is 1 per 5 million population. So 200 such centers are required. Then secondary center, which are known as service center, 1 for every 5 lakh population. And target is that we should have 2,000 such centers. And the lowest level, it is the primary eye care center or vision center. And our aim is that there should be 1 vision center for every 50,000. That means total 20,000 vision centers are there. The issue is in our country, all these 3 facilities are sufficient in number, but the primary eye care services are extremely affected. Instead of 2,000 vision center, we just have 4. Instead of 20,000 vision center, we just have 4,000 vision centers in our country. So we need to give emphasis to primary eye care services that include ophthalmic technician availability at the vision centers, and at the community level, ASHA workers should be trained, and they should act like a bridge between the vision centers and the community. some facts about like what amount NPCB is giving in relation to various type of surgeries, sponsorship to various NGOs, and even private sector can be a component of this thing. For every cataract surgeries, NPCB is paying 2,000 rupees to NGOs. For other surgeries, for DR, for childhood blindness, for glaucoma, it is also 2,000 rupees per surgery. And for keratoplasty, it is 7,500. And for VR surgery, is 10,000. All the NGOs, they can register them into NPCB portal, and finally, when they will submit the reports, they can be given money for these surgeries. There are certain recurring grants also for school vision screening program, or even for presbyopic spectacles. The NPCB is paying 350 rupees per spectacles to children, and also for adults for presbyopia. For cornea collection, if any institute is collecting cornea, eye donation, they are paying 2,000 rupees if it is eye bank with processing facility, and 1,000 rupees if it is just an eye donation or eye collection centers. Even for IEC activities, 20 lakh and 10 lakh rupees are paid to the various states for conducting awareness programs as per NPCB guidelines. NPCB also provide recurring grants to district hospitals, sub-district hospitals, primary eye care centers, they called vision centers, for eye banks, for eye donation centers, and also to develop multi-purpose district mobile units and for teleophthalmology activities. For all these activities, the NGOs, they can apply to NPCB, and government gives this much of money for operating these respective centers. To summarize, the key role of NPCB is to provide free cataract surgeries for the poor, school vision screening program for myopia among school children, where free spectacles are being distributed, collection of donated eyes and providing free keratoplasty surgeries, diagnosis and treatment of diabetic retinopathy, squint, glaucoma, low vision, that means all these diseases have been covered, infrastructure development in terms of vision centers, eye banks, eye wards, training of eye surgeons and paramedical ophthalmic assistant, and creating awareness activities for prevention and promotion of various disease. And beside this, their responsibility is to develop monitoring and evaluation for various programs under NPCB. Thank you very much. Thank you.
Thank you, Dr. Praveen. That was a excellent update. It gave us all the data on what the prevalence rates of blindness are, what the requirements for cataract surgery are, and how we can tackle the problem of blindness in the coming years. Do we take any questions at this stage?
Maybe at the end.
Okay. Okay, thank you. May I now call upon Dr. Fairuz, who's an excellent oculoplastic surgeon and a wonderful teacher, to tell us about management of ptosis.
Good afternoon, everyone. I take this opportunity to thank Dr. Hunavar and the Member Scientific Committee of AIOS for this invitation. And I should actually, say that this is the best part of AIOS that I always look forward to, the PG teaching program. So I'm going to deal with the management of blepharoptosis here. So when we talk about ptosis, there are many ptosis. You can have brow ptosis, you can have eyelid ptosis, which is called blepharoptosis, and you can even have lash ptosis. So we are going to specifically deal with blepharoptosis, which is otherwise commonly known as ptosis in our language. As you all know, eyelid plays a major role functionally and aesthetically for the eye. It plays as a protection to the eyeball. If eye is the window to the world and the soul, of course, eyelid is the shutter. If the shutter falls down, there is no light into the eye, and functionally, it can affect the vision. Let's see how. I have no financial disclosures or interests here. It is very, very important on a PG level that you know the eyelid anatomy. I'm sure you all know which are the elevators of the eyelid. Yes? Frontalis, levator palpebrae superioris, and Muller's muscle. So how much millimeter of the eyelid is lifted by the levator palpebrae superioris? You have to give me the answer. Approximately 12 millimeters? Well, yeah, approximately it lifts 15 millimeters, levator palpebrae superioris. Muller's muscle, 2 millimeters. And even frontalis muscle has a role of lifting the eyelid for 2 to 4 millimeters. All right, yeah. So this classification is very important even to plan the management of blepharoptosis. It's classified as congenital. This is basically for the postgraduate sitting here. Congenital further classified as simple and complex. And acquired could be aponeurotic, which is very common, acquired aponeurotic ptosis, myogenic, neurogenic, mechanical, and traumatic. So as you all know, it can run in family. There can be a family history of ptosis. These are two siblings who has a ptosis in the family. So family history is also very, very important. So that adds to the fact that ptosis can be familial in a congenital ptosis. All right. I'm sure you have gone through the basics of ptosis evaluation in the morning over here. I'm not going to go into the detail. A quick revision of that. In the history, you have to ask the patient about the age of onset, the mode of onset, laterality of course, diurnal variation, which is very, very important, especially in acquired ptosis, progression, history of trauma, forceps delivery, prior surgery, medications if any, and also periocular and systemic symptoms. This should be useful for you for your practicals as well as your theory. So simple blepharoptosis, the patient has a droopy eyelid, and this is what a simple blepharoptosis is in a child. So what is a very classical feature in a simple blepharoptosis is what you see in the second picture here. What is that? What do you see here? What do you call this? Down gaze, lid lag, right? So on down gaze, there is a lid lag, but this is opposite in the case of acquired ptosis. And why does this happen? Yes? LPS is embryologically poorly developed, so neither it contracts, neither it relaxes, right? So it doesn't pull the eyelid up, neither does it allow the eyelid to come down. And this is very, very classical of a congenital simple blepharoptosis, okay? So this is yet another child where of course you can see the lid crease is well formed, right? So the LPS is good. When in a child who comes to you telling there is a ptosis, first you look is at the lid crease. If the lid crease is present, that indicates that the LPS is not that poor functionally, all right? So this baby has a very mild ptosis with a very good lid crease over there. So this is an extreme case of poor function of the LPS, and this is another case of congenital ptosis with a good LPS. Now we come to the complex blepharoptosis. So what is the diagnosis here? I have two pictures for you here, left and right. What is the diagnosis? Quick, I have only 25 minutes. What do you see here? So the baby has a ptosis in the left eye. The baby doesn't have a ptosis in the other eye. I have not surgically corrected the child. So it's a Marcus gun jaw winking phenomenon in the child, right? You see how the baby has clenched the teeth. Yeah, you feed the baby something in the office and then see whether it's a complex ptosis. So this is a complex Marcus gun jaw winking phenomenon in this child. So yes, we do see patients and even adults coming with this condition. So assessing Marcus gun jaw winking phenomenon and not missing that in the list of evaluation in ptosis is very, very important, because the management drastically changes in this situation. Similar in this case as well. Now you should always look for the elevation of the eyeball. All right, why? Function of the? Yeah, easy question. LPS and superior rectus, because it has a common embryological origin. Okay, yeah, so they can have associated monoocular elevation deficiency also. So that's also very, very important. Now this is a very complex congenital ptosis, all right? So the baby has bilateral congenital ptosis, Marcus gun jaw winking phenomenon in the right eye, and what you see here in the left eye is a monoocular elevation deficiency. So everything is there in this child. So even if it is a baby or a child, you have to take an effort, not complaining that the child is uncooperative, to take down and note all these points, because it needs even a strabismologist intervention at this point of time when the muscles are involved. What is this? Diagnosis. It's written there. Yeah? Blepharophimosis syndrome, right? Yeah. So it's otherwise known as the congenital tetrad syndrome. I always put this slide in my presentation because this came as an essay question for me for my postgraduate exam. I couldn't answer it well. I was not prepared. I didn't know the classification then. After that, in every ptosis presentation of mine, I used to put this for the postgraduates. All right? So blepharophimosis syndrome is also known as congenital tetrad syndrome. It has 4 features, and that is why tetrad: blepharophimosis, ptosis, epicanthus inversus, and telecanthus. It does have a classification also. Depending upon the ovarian function in a patient, it's classified into type 1 and type 2. Primary ovarian failure, type 1. Type 2, no systemic association. And a Callahan classification depending upon the features which is present in these children. Well, so what is the type in this mother? Do you want to classify it? So you have a mother who has a blepharophimosis, who has undergone a surgery. There is a baby again with blepharophimosis syndrome. What type is it? Very easy. I already told you. Type 1 or type 2? 1 with primary ovarian failure. She has a baby in her lap. Right? So it is type 2. No ovarian failure, no systemic association. So she has a type 2 blepharophimosis syndrome. All right? So asking the history, getting to know the parent, everything is very, very important. Even any child, especially a female with blepharophimosis syndrome, we actually evaluate them gynecologically also. All right? This is a very interesting case that came into my practice. This was like many years back. All right? So what is the diagnosis here? Right eye ptosis or left eye ptosis? Yeah? Right eye ptosis, okay. Anything else? Heterochromia, yes. Anything else? Is it seen? Meiosis, correct? Yeah. So she has a meiosis and a heterochromia, all right? So this lady was going to get married, and she said that she wants to get this ptosis corrected. It was a mild ptosis, but then it happened to be a Horner syndrome. So these cases again needs a systemic evaluation. All right? Perfect. So preoperative evaluation is very, very important. Before jumping on to advising a surgery to a patient, preoperative evaluation is so very important. You have to look at many, many things: facial asymmetry, head posture, eyelid crease. Frontalis overaction is very, very important again. In severe congenital ptosis, if you're planning for a frontalis sling, Marcus Gunn-jaw winking phenomenon, already covered. And of course, the ptosis measurements, I'm sure it has been covered in the morning. So there are 3 rules that I always never forget. Always rule out pseudotosis. 1, assessment of the best corrected visual acuity, because there can be an associated amblyopia, which we don't want to miss as a physician, because that also requires treatment. And the assessment of ocular motility. You can miss many, many things if you just miss the ocular motility in a ptosis evaluation, which is very important. So this patient came to me, a gentleman, complaining of a ptosis, and he said it is like an acquired. But looking at his features over here, there is no lid crease at all, right? In an acquired ptosis, the lid crease will be present, but it will be higher, right? All of you know that, right? Yes. But this is total absent lid crease, and I didn't believe him. I was like, no, this has to be congenital, so I want to see your pictures. So we often ask the patients before going for a surgery to bring their pictures, the past pictures, series of pictures to evaluate when the onset was, and when did he develop. So he said, no, it is acquired. It was never there when I was a child. I did not trust him. Well, he came up with the pictures. There was no ptosis when he was a child, all right? So this was a case of acquired blepharoptosis where the LPS has really, really detached far away from the tarsal attachment and absolutely no lid crease. So sometimes there can be variation as well, which you have to go back and check, all right? Now going on to the management of blepharoptosis, there are certain things that we consider before, again, as surgeons, we jump into the management. The risk of amblyopia has to be assessed, especially in children. There are situations where the ptosis will be mild. You don't have to really take it up as an urgent case for a ptosis surgery. You can still wait if there is no risk. Functional vision is very, very important, especially in these old patients who have an acquired aponeurotic ptosis. They get their cataract surgery done, but they have this aponeurotic ptosis which is never addressed. And the vision is still there, not good, right? So the eyelid is, in this patient, as you can see here, it's completely covering the pupillary axis. And at certain times when the patient is tired, even the other pupil is covered. So as a cataract surgeon, you should also be aware of the fact that after giving them a good IOL inside, whether the shutter of the eye is also working properly. So they might require an aponeurotic ptosis repair. So it's very, very important. Function is very, very important. There are patients who actually doesn't have, because of the severe ptosis, they may not have the field of vision in this laterally. So all these things has to be is a concern. Now next is a cosmetic concern. Most of these patients come during their 20s, early 20s, late 20s, when they are going to get married and they want a cosmetic reformation and aesthetic improvement of their face. So surgical management of blepharoptosis depends upon the type, the severity, most important, the levator palpebrae superioris action, and I also consider Bell's phenomenon before I take a decision. So these are the list of surgeries depending upon the severity that we do consider. I'm sure Dr. Grover also agrees to it. Mullarectomy or fascinella servat, LPS reattachment or resection, supramaximal LPS resection, Whitnall sling and tarsofrontal sling. Now this depends upon how severe the ptosis is. In mild ptosis, we often go and do mullarectomy or fascinella servat. Moderate, LPS reattachment or resection, and in severe, these are the surgeries that we often prefer. Now what do you mean by this severity of the ptosis? So basically, depending upon the palpebral fissure height and where the eyelid is situated and the levator palpebrae superioris action, this is how we assess. So according to the Beard's method, the father of ptosis, who have taught us many surgeries and many numbers and rules in the ptosis surgeries, depending upon the pupil, it's considered mild if the eyelid stays at the upper border of the pupil, moderate if it is in the middle, and severe if it is in the lower border of the pupil. All right? Depending upon the LPS action, it's very, very important for you for your exam, and this is sure do that your examiner will ask you about this. Poor if it is less than 4 millimeter, fair 4 to 6 millimeter, good 7 to 10 millimeters, and excellent more than 10 millimeters. I'm sure you can go back and read the theory. So this was, you can see here. What is this? Mild ptosis of the left eye. And why have I put this here? You know the phenylephrine test, right? Yeah. Yes? You know that, yeah. So in mild ptosis, we actually do a phenylephrine test in order to assess what kind of surgery we would want to go ahead, in order to know the action of the Muller's muscle. All right, yeah. So you can see how well it's corrected after the phenylephrine test, and this patient underwent a mullerectomy of the left eye. All right. So this is a baby with a congenital ptosis, but as you can see here, the lid crease is quite prominent. Very mild ptosis, although it was congenital, who required only an LPS resection of the eye. All right. Yet another case, a little bit more severe as far as the palpebral fissure height is concerned, but he still has a lid crease. So an extended levator resection was done in the left eye and he was corrected. Now this was a young lady who came to me complaining of ptosis in the left eye. But if you actually see her, she does have a very mild ptosis in the right eye also, but she was just not willing to undergo a surgery for the right eye. So it was quite challenging because you have to kind of, in order to symmetrize, you have to give an under correction of the ptosis correction that you're doing, and that's exactly what she received here. And even in this eye, she has a very high lid crease. So it's very, very difficult to give a high lid crease when you're actually attaching the levator palpebrae superioris. A little bit of here and there adjustment, and she gets a good correction. So levator palpebrae resection and reattachment, I'm just not going into the theory, but I'm sure you all know that. So basically you enter through the skin, you identify the septum. When you open the septum, you see this fat, the preseptal, the postseptal, retroseptal fat pad, and just behind the fat will be the levator palpebrae superioris. Okay, so you expose the levator palpebrae superioris, then you come to the tarsus, you detach the levator palpebrae superioris from the tarsus, and then finally, depending upon how much height you want, depending upon the measurement on table, you actually stitch the levator palpebrae superioris onto the anterior edge of the superior border of the tarsus, in the center, medially and laterally. All right. So this was a very interesting case that I want to show you. So this patient came with a ptosis in the left eye. He says, I have ptosis in the left eye, a Chinese patient. What do you think? Just left eye? Yeah? What would you tell him if you saw this patient? Yeah, I told him he has a ptosis in the right eye also, a mild ptosis in the right eye. And in fact, I tried to convince him, you know, we might have to do both the eyes, but he's like, no, only the right eye. And why did I convince him? I tried to convince because there is something called the Hering's law. All of you know, right? Yeah. So when you lift the worse eye, the other eyelid can droop. So all these patients who have a mild ptosis in a, you know, in one eye and severe ptosis in the other eye, you should always tell them preoperatively that this is what is going to happen to you, and he never listened to me. All right. So this is 2 weeks post-operative. All right. So you can see this is corrected and this has further dropped. So then he went for the surgery of the right eye also. Sorry, this is 6 weeks post-operatively, which has further dropped. Okay, 2 weeks, 6 weeks, it has further dropped. Then he went for the ptosis surgery of the right eye also. So Hering's law plays a major role in bilateral asymmetric ptosis, which has to be discussed with the patients. Now in older patients like this, he has an aponeurotic ptosis. As you can see here, left eye more than the right eye. And there are many other things which has happened in the periocular area over here. He has a dermatochalasis, all right? Severe dermatochalasis in the right eye. If I lift that up, there is going to be a hooding of the skin, and that can even affect the vision and the field of vision laterally in this case. So there are situations in older patients where we combine ptosis surgery with other periocular surgeries as well. What did I choose? I chose to do an LPS resection with the blepharoplasty in both the eyes in this patient, and the patient is happy. Otherwise, you lift the eyelid and then the dermatochalasis will start hanging down and it's not going to benefit the patient. Yet another patient, a male patient bilateral, you can see he has also got a brow ptosis. He has a ptosis, dermatochalasis, and a brow ptosis over here. So a mixture and a combination of LPS resection, blepharoplasty, and brow pexy was done in this case. So this was again a case of congenital ptosis, severe. His LPS action was less than 3 millimeters. So I used to do a lot of frontalis sling surgeries earlier, but I'm gradually shifting to the supramaximal resection of LPS in these cases because cosmetically it looks slightly better and in a long term a better outcome than frontalis sling surgery, and this is what the patient underwent. Whitnall sling surgery again in severe ptosis you do, and she actually received a lid crease formation also, an artificially created lid crease over there. Tarsofrontalis sling, yes, we do in severe ptosis where the LPS action is very, very poor. I have experience with silicone sling, but Dr. Grover has done a lot of fascia lata. Silicone sling, yes, it works. We can also do a readjustment if it is required later. And this is a patient who has undergone a tarsofrontal sling. So how many minutes more do I have? Last minute. Okay, so I'm gonna skip this video of that. So severe ptosis is frontalis sling surgery. Marcus gun jaw winking phenomenon, what we do is we resect the LPS because there is a winking which is associated with the jaw movement. So you want to actually abolish the movement of the overaction of the LPS. So LPS is resected and then we give a frontalis sling in these cases. Blepharophimosis syndrome, medial and lateral canthoplasty is done along with frontalis sling surgery, and this is a child who has received a medial and lateral canthoplasty with frontalis sling surgery in blepharophimosis. A small baby with blepharophimosis syndrome, when you want to avoid the risk of amblyopia, we give them a temporary tarsofrontal sling, and this was done with an ethibond suture, a 3-0 ethibond suture, a small elevation of the small eyelid, and this is how the child is after the surgery. There can be situation like neurofibromatosis with causing a mechanical ptosis, as in this case. She has got cafe au lait spots, and what we did was excision of the levator LPS, resect maximum, and then gave a LPS resection. So in such cases where there is bilateral involvement of this massive neurofibromatosis, she has got a severe ptosis of the left eye and a ptosis of the other eye with this lesion over here. She received a debulking, facelift, internal brow fixation on the right side, debulking and tarsofrontal sling on the left side. So we need a lot of combination. This is a 68-year-old lady with droopy eyelid and diplopia. A old lady presenting with diplopia, what is the first thing that you would think of with ptosis? Myasthenia gravis. Okay, eyes test is very sensitive. Then you do the edrophonium or the neostigmine test, and she was positive for that, so it was an ocular myasthenia. What about a small young patient, a 20-year-old male with progressive droopy eyelid, and he has ocular motility limitation also? What would you think of? CPEO, chronic progressive external ophthalmoplegia. How do you confirm it? Muscle biopsy, all right? Ragged red fibers, and it's very, very important when you're suspecting a CPEO. This is a 23-year-old male with road traffic accident. What he has is, I'm finishing, sir, maybe 30-second, proptosis, total loss of vision, complete ptosis, ocular motility limitation, and he has a bruit. Okay, so this was a case of an arteriovenous fistula involving the internal carotid artery in this patient. He underwent all these interventional vascular surgeries with clipping, etc. of the arteries, and still he had a complete ptosis. So in traumatic cases, we don't again jump into surgeries, we wait. And this is after 4 months, doing nothing, observation, all right? So trauma, you're always justified to wait from 6 months to 1 year. And this is a very important case that I want to point out. A 54-year-old lady who was referred to me for a ptosis. I felt it's more than ptosis. There is fullness in the upper eyelid also, all right? This was a case of a T-cell lymphoma, a high-grade T-cell lymphoma in a patient who was referred for a case of ptosis. So you should be aware of all the differential diagnosis. You should be aware of evaluation, and this is how you take a correct decision in the management of these patients. So for me, etiology definitely tells me what decision that I should be taking, and surgical management definitely depends upon type and severity, and amblyopia treatment has to be taken care, if at all, if it is present. Thank you very much for your patient listening.
Thank you, Dr. Feroz. So now that the lids have been done, we can go inside the orbit, and we have Dr. Grover, one of the masters and doyens of oculoplasty in India, who is going to tell us about the logical approach in orbital tumors. Dr.
Thank you,
Grover.
Pradeep. Before we venture into muscles and squint, okay. So you heard that excellent overview of congenital and acquired ptosis by Feroz. We move to orbital tumors. This again is an area which you will encounter in your examinations whenever a case is available. It would be a long case for you. So just as ptosis is. So I would like to take the opportunity to thank open way. The opportunity to thank the scientific committee for this opportunity to make this presentation. If you just take this out and put in, वो काम कर जाता है कई बार. इसको निकाल के दो. Okay.
The slide is going outside the orbit.
Yeah. Okay, this is much better now. So can we have the time reset to 25? 18 now. Okay. 3 minutes for Pradeep. Okay, so when we look at orbital tumors, the things that we need to know are, one, look at the basic anatomy of the orbit, how an orbital tumor would present because of the anatomical factors, and what the different presentations could be as a result of the anatomical change that it brings about. Then we look at the clinical diagnosis. The relevant investigations are very important to help us reach a diagnosis, which in turn lead us to the appropriate management. Now, we know the volume of the orbit is only 30 milliliters, and globe occupies only 1/4 to 1/5 of that, and the rest of it is the orbital spaces. And what are the spaces? Within the extraocular muscle is the intracorneal space, and outside the muscles, what is this? Extracorneal space. And just under the bone is the potential subperiosteal space. Where is the fourth space? Subtenons, which is again a potential space. So we have these spaces. Depending on the location of the pathology, they would present differently. If they're intracorneal or intracorneal with extracorneal extension or predominantly extracorneal, the presentation would vary. So when we evaluate the cases of proptosis, as elsewhere, history taking is critical. So is examination, and investigations are very important in the orbit. Now, age and sex is very important. You know that diseases of infancy are different from those of an adult, and those in pediatric age group are again quite different from those in the adults. Certain diseases have predisposition for a female sex or male sex. Then we look at the symptoms that have occurred as a result of structural changes and as a result of alteration of physiology. Time period of happening of things is again the third important factor. Systemic involvement in several diseases in the orbit is again very important, and family history offers you important clues in orbital diagnosis. So if you have something happening over a period of minutes, what pathology would you think of? An acute hemorrhage? Hemorrhage within a tumor could be a factor which would occur within minutes, or an acute allergic reaction, edema taking place in the orbit. If it occurs over a period of days, what would you think of? 2 days, 1 day? An inflammation, obviously. If it occurs over a period of, let's say, over weeks, probably a rapidly growing malignancy. Over months and years, maybe a benign pathology. So these would help your computer eliminate a lot of diseases. Once you've seen the age group, once you've seen the time course, you would only be thinking of certain pathologies. So that is the importance of history. Then look at the kind of changes that have been produced. What kind of displacement has taken place? What kind of protrusion has taken place? Whether there have been sensory changes or motor changes, these are the functional changes that have taken place. And whether there is an associated dry eye, whether there is a greater watering, what kind of swelling or redness is present. These are all very important clues in the history which will lead you to a diagnosis. Associated systemic conditions like thyroid eye disease or and other features of lymphomas are again very important clues. Several diseases would have a family history. So once you have the history, you have zeroed in on certain things, and your examination would help you to go further and pinpoint the pathology. Now, general assessment, as we always say, is important. Ophthalmic examination, we've already seen how the different ocular structures could be affected, and systemic examination is important. So one, orientation, facial symmetry, and the test where the patient's cooperation is important, the psychophysical test, visual acuity, visual fields. We know that the pressure over the nerve could affect visual fields and visual acuity. We need to look at the color vision, which may be an early clue to pressure and effect on the nerve, optic nerve. Corneal exposure may be a manifestation of the proptosis caused by the tumor. Changes in binocular vision, diplopia, ocular motility, and the force duction test, which is again important to help you distinguish a paretic pathology from a restrictive pathology. Eyelid changes secondary to the orbital pathology are common, which you need to look for. You need to look for the anterior segment examination, particularly the pupils, and exposure. Intraocular pressure gets affected in several orbital diseases where there is a diffuse pathology because of rise of intraocular pressure, such as in thyroid exophthalmos. And look for pressure signs. When a tumor intraconal grows, presses on the globe, you would see disc edema, you may see choroidal folds, retinal folds. Assessment of exophthalmos again is important. Measurement of dystopia, whether the globe has moved out, in, down, or up. And if you use two scales, you can quantify that. You also need to measure the exophthalmos, a simple device like Ludes, or measurement within Hertels. Hertels, you must know the procedure. You must also record the bar reading every time so that the readings taken on subsequent occasions are comparable. Orbital assessment obviously is important. So one, orbital tension is important to see whether there is an increased resistance within the orbit, which would indicate a solid tumor, or if there is a very minimal resistance, it may indicate a compressible tumor or may indicate a minimum pathology. You need to examine the orbital area just as you would do for a tumor elsewhere or a mass elsewhere, as you learned with your K-Das or your Hamilton-Bailey. So look at all those features. And Valsalva's maneuver is important in orbital varices. Auscultation is important in the keratico-cavernous fistulas that Fairuz was talking about. And systemic examination to look for cafe au lait spots, other hemangiomas, other signs of systemic diseases. Laboratory investigations offer a clue in certain parasitic infestations, certain other pathologies, and investigations, especially imaging, have a critical role in the evaluation. Plain X-ray orbit is rarely done, but you theoretically need to know about the various views that are useful to you. Waters' view is often very important and does offer you certain clues, but the most important is to know these changes that take place, which are important both in plain X-rays and in CTs. So orbital enlargement, symmetrical or asymmetrical, presence of calcification, presence of enlargement of superior orbital fissure, or of optic phenomena which can be uniform or irregular, may all offer important clues. Similarly, changes in the bone density, which may include hyperostosis, osteolysis, which may be diffuse or localized. And similarly, the soft tissue changes in the orbits and surrounding areas may be very important. So CT scan often is still a method of choice in orbital diagnosis, where you look at the contrast differences based on the densities obtained on passage of X-rays through the tissues. So the different densities which you measure as Hansfeld units are important, and these are the attenuation values which you look at. And it is important to use advanced spiral techniques or the more advanced techniques, and use finer cuts where indicated to get the right kind of idea. And you can have those where the tissues are highlighted better, or where the bones are highlighted better, the bone density windows and the tissue density windows. In MR, it is essentially the proton density that you are measuring, and the more advanced machines can give you 0.6 to 1 millimeter thin slices, and you have several newer fat suppression techniques, development of stir sequences, development of flare. You need to be aware of these to utilize, to make the best use of these films. MR angiography, MR venography may be indicated in relevant cases, and you need to distinguish the various views that you get. You have the T1 weighted images where the vitreous is light, has the same density as the fat. You have the eggshell cuts, you have the coronal cuts, the sagittal view, and you have the T2 weighted images where the vitreous appears white. So you have to look at all these differential characteristics in T1 weighted, T2 weighted in order to make an appropriate diagnosis, and these imaging techniques have revolutionized your diagnostic ability. CT scan versus MRI, they can both be complementary, but CT is often preferred if you want to look at the surrounding areas as well, including paranasal sinuses, surrounding pathology, and particularly if you want to look at changes in the bony structures. But MRI provides greater details about soft tissues, and we'll also look at the better resolution for cranial purposes. Of course, there are contraindications for MRI like cardiac pacemakers and any metallic thing. So MRI not just has a better visualization near the orbital apex and cavernous sinus region, but also in intracranial lesions, and is becoming important in pediatric cases, particularly in retinoblastomas, where you want to avoid a CT because of the risk of radiation exposures. So complementary because they can give additional information about the nature of pathology. Ultrasonography is a useful technique because both with A scan and with B scan, you can look at it in your clinic, you can do serial examinations, and you can do tissue characterization with the help of ultrasonography. Biopsy is again the most important factor in tissue identification. Fine needle biopsy is only indicated in cases where a differentiation between an inflammation and a malignancy needs to be made. In many other cases, you would do an incisional biopsy. And wherever a complete excision is possible, the choice is excisional biopsy. And you can really make a good diagnosis, final diagnosis, based on histopathology and immunohistochemistry. Let's look at some of the tumors in different age groups. Let's look at the spectrum of tumors or conditions which affect infancy, childhood, and adults before we go on to the surgical management. In infants, you need to look at conditions such as craniosynostosis, where you have changes in the orbital structure because of the craniostenosis, premature closure of the sutures, encephalocele or meningoencephalocele, and microphthalmos with cyst again may be a presentation. You may have teratomas, capillary hemangiomas, metastatic retinoblastomas, and orbital retinoblastomas. So these are the conditions which present in early childhood, early infancy or childhood. Now this is an encephalocele here. In children, you need to exclude inflammatory disorders if you have to make a diagnosis of a tumor. Parasitic infestations may present very much like tumors, and the various tumors of childhood include all these entities, some of which we can look at: a dermoid, external angular, internal angular, orbital. All these are important. Optic nerve gliomas, meningiomas, plexiform neurofibromas with many systemic associations, neurofibromas are all important. Vascular lesions are again very important both in childhood and in adulthood, and you need to be aware of the new International Society for the Study of Vascular Anomalies classification, which classifies them into vascular tumors, slow flow vascular malformations, and fast flow malformations. So the classical descriptions as cavernous hemangioma, capillary hemangioma are now more often referred to as slow flow, fast flow malformations, and you need to be aware of this classification. So you may have a capillary hemangioma which may be associated with similar lesions elsewhere in the body. You may have venous malformations or lymphovenous malformations, earlier called lymphangiomas, they are now lymphatic malformations. In adults, you need to have a differentiation of tumors from thyroid exophthalmos, which can be the commonest cause even of a unilateral proptosis. Vascular lesions in adults are important. Again, a lymphovenous malformation, a keratico-cavernous fistula, varices, tumors which may again be primary, orbital tumors, lacrimal gland tumors again differently, and then secondary tumors which may come from surrounding structures and less commonly as metastasis. One of the commoner ones is a pleomorphic adenoma of the lacrimal gland, but you may have malignancy in a young child, young adult with features of pain added to proptosis, relatively rapid growth, and adenoid cystic carcinoma. Orbital dermoids may present in adults, neurofibromas, schwannomas, lymphomas in the elderly. So these all need to be looked at. You have to look at the specific age group, you have to look at the kind of pathology that you see on imaging to make a differential diagnosis in your mind before you decide on the management. Lid tumors, frontoethmoidal mucoceles, tumors from the frontal sinus may all come into the orbit. Pathologies in the maxillary sinus, they may all affect the orbit. That brings us to the approaches to the orbit. Well, important is for you to know the choice is made based on the surgical space occupied, size and location of the lesion, the suspected pathology. Your approach becomes different for a resectable tumor like a benign, well-defined tumor versus a poorly defined malignancy where your target may only be an incisional biopsy and further management with radiotherapy or chemotherapy. So the goal of surgery will accordingly vary. You always try and take the most direct approach. You try avoid crossing the optic nerve. If it is on the lateral side, you would prefer that. If it is in anteromedial, you would go anteromedially. And you try and take an aesthetic approach, hide skin incisions, avoid bone removal where you can. So minimally invasive approaches and aesthetically appropriate approaches have become the buzzword in surgery of the orbit. So we'll briefly look at the various options. The anterior orbitotomies, which can be through the skin, through the conjunctiva, and when you combine an inferior conjunctival or phalangeal approach with a lateral canthotomy and cantholysis, it becomes a swinging eyelid approach. Medially, you can do a transcarancular approach. For lateral or large tumors where bony removal may also be needed, a lateral approach or a lateral orbitotomy is done. For those with combined intracranial extension or very close to the orbital apex, you do a transcranial approach, or sometimes you need to combine the approaches. So the commonly used approaches now for orbitotomy are these that stay aesthetic. You can use a Burke's incision, which is at the lateral canthus. You can use a lid crease incision, or more often the lid crease incision is now preferred for lateral orbitotomy. For the anterior orbitotomy, you can use a subbrow approach, or this is a subbrow approach where a tumor has been removed and the patient has this kind of a pathology in the superior orbit has been taken care of by a subbrow approach. eyelid crease approach is again a very important approach because it causes no scar. Your scar can be hidden within the line of the lid crease. The mass like a medial extracorneal mass can be taken care of by an eyelid crease incision, as you see here, but transconjunctival approaches are now used much more often, like this inferior orbital mass. Now, you would very easily go in from the orbit, from the inferior fornix, and get rid of this mass, as you see here. So, supromedial conjunctival approach has been used here for this tumor. Lateral orbitotomy, upper eyelid crease incision is now the favored approach. Traditionally, you had the Stallard-Wright incision or the Burke-Reese incision. But now upper eyelid crease incision is very much the favored incision because of minimum scarring and least possible dissection. We'll very briefly look at this video where we're going through the eyelid crease and we have incised the muscle, orbicularis muscle, defined the lateral orbital bone. This is the marking of the incision that we're going to make in the periosteum. Lift up the periosteum to go into the subperiosteal space. Then you dissect the temporalis muscle. Once you've gone lifted up the periosteum, you can do your osteotomies by using a striker saw or one of those automated saws, and then you remove the bone, give an incision in the periosteum, expose the tumor, dissect by blunt dissection, take out the tumor, use a cryoprobe for the final dissection, and then you can carry out a closure. The transcranial orbitotomies are indicated only for the lesions which are very close to the apex or with intracranial extension. And a bicoronal approach is used along with a neurosurgeon for a transfrontal craniotomy like this. And after an osteotomy is made, the tumor is exposed and removed. Those with very large tumors may require a lateral approach to be combined with an anterior approach, or a lateral approach to be combined with an intracranial approach. And these combined approaches help you in removing multi-lobed or very much larger tumors. To conclude, appropriate evaluation, including a good history taking and examination, is the key to decision making in orbital tumors. Investigations, especially imaging, is very important in the orbital diagnosis. The approaches to orbital tumors are increasingly minimally invasive. They provide an excellent exposure for safe removal of tumors while retaining the aesthetics of the patient, which is important for his confidence and his well-being and his ability to face the world. Thank you very much.
Thank you, Professor Grover. I think since Dr. Santosh Honawar has not been able to come, we will postpone his talk to the next, and I will be presenting the next talk on the strabismus, indications, dosage, and techniques. So, dear friends, there are no financial disclosures, but the objective that I would like to disclose is this, that we would like you to go after the talk to be a changed person. Strabismus surgery, if we talk of indications, traditionally, since we are in the oculoplasty, we always consider that it is basically a cosmetic problem. Yes, it is a cosmetic problem, but not just that. It is also affecting the personality, but not just that. It also creates diplopia, so maybe creating problems, we need to manage that. But beyond all this, the basic objective is to restore the binocular vision and stereopsis. The stereopsis is the new goal post. For ophthalmologists, we talk about 6/6 vision. It's not enough. We are going to talk about stereopsis and good fusion. So remember, in this talk, we are not just talking about strabismus, but stereopsis. Because the 3D eye surgery is now come up. Now, our retina surgeons, anti-segment surgeons are operating with heads up, with the binocular goggles and seeing it. We had done a study on our residents, how their surgical performance is there if we induce anisometropia in one of the eyes. So on the surgical simulator, which is an instrument like this, we checked how is the surgical score, and we found that if we have a 0.5, 1 diopter, 2.5 diopter, the surgical score starts declining very, very drastically. It almost correlates with the stereopsis. The Spearman's rho factor is 0.88. How can we assess stereopsis? We can do it both for near and distance. For near, we can do by these tests. The Randot on the left hand side, on your right hand side, and the TNO test on the other side. For the distance, we have the Frisbee-Davis distance, FD2, which is done at a distance of 6 meters, and we have a distance Randot, which can be done at 3 meters distance. And a simple modified Lang's true pencil test is something which you can do on the bedside. Every child you can test whether he has binocular vision or not. Even you, if you close one eye, or if your one eye is masked by a higher refractive error, you will not be able to pass this test. So this is a very good test, and it can tell you about the binocular functions. Now this case story I usually present, so if you have heard a talk, you may have seen this child who is newborn is with straight eyes. At 3 months, the child starts deviating in. So the father, who is the pediatric ophthalmologist of US, Dr. Kenneth Wright, sees his child having this. He does a proper refractive correction, and at 6 months he finds with the Bruckner's reflex, you can see the left eye is still turning in. So there is a esotropia in spite of full refractive correction, needs surgery. And the surgery is done at 6 months of age, and this child has grown up to be like any other normal boy with stereopsis doing all the normal tasks. That is what is the goal for each and every child of our country. For exotropias also, you have to remember, if it is intermittent, we can delay, but if it is constant, we will have to operate early. So I generally say we are all fond of cricket, and we are all fond of 4s and 6s. So these two magic numbers we have to remember. 4 and 6 weeks for congenital cataract, we all know, right? 4 to 6 months, we should pick up infantile esotropia and manage it by first year of life. 4 to 6 years for intermittent exotropias, nystagmus, refractive errors. All these problems need to be managed if we want the binocular vision to be restored. How can we manage strabismus? Non-surgically we can do, the first step is proper refraction and proper prescription. Second is, if there is an amblyopia, we will have to restore the amblyopia. We have to see that binocular vision is restored. Orthoptic exercises for mild exotropias and prism neutralization can be done as a non-surgical approach. Coming to surgery, we have the weakening procedures and the strengthening procedures. But first, little bit about amblyopia. All of you should know that the first thing that has to be done is amelioration of the amblyopogenic factor. So the proper visual rehabilitation has to be done. It can be also corrected by using occlusion, which may be full-time or part-time. Penalization is another approach which you must be aware of. It may be an optical penalization, that means more plus, or atropine, that means you cycloplege the good eye, or you may have a combined approach, the COAT, combined optical and atropine therapy. Or you may use CAM, pleoptics, red filter treatment, which are not very useful as such. Medical treatment using levodopa and citicoline. But the most important thing is the active vision therapy, and nowadays we have the use of binocular dioptics in addition to that. So the occlusion schedule, you should all be aware of that we have 2 schools. One is the full-time patching, that is according to the age, the good eye is patch from up to 2 years, 2:1, and then as per the age 3, 4, 5 or 6:1. Beyond 6:1, because the week has just 7 days, we still have 6 days. So it's not that 9 years old child will be done 9:1. Okay. So monitoring fortnightly in infancy and monthly later. Part-time patching is the other strategy which we do 6 hours dominant eye daily. It's a compromise because the child doesn't want to patch during the school time. We do it off school. Now the binocular vision stimulation using the newer technology, and nowadays the virtual reality games are what we are using. The Oculus based or the virtual reality box we can use, and we have seen that the binocular vision stimulation can be done, and one of our residents had done a thesis on this. So we found that it is effective and going to be better because it gives binocular vision therapy. I won't go into the video of this. Let's talk about strabismus straight away. So what is the diagnosis in this case? The spot. How many people would be able to say there is a squint? How many? Just raise your hands. Okay, what type of squint? Exotropia, right? You think it is an exotropia, but that is the problem. Appearances are deceptive. So we have to be careful. We need to observe, but we also need to confirm. Then we have to infer, plan, and execute. Generally, I say the recipe in strabismus is OCIPE. Observe, confirm, infer, plan, and execute. So what appears to be squint may not be. Like in this case, you see the upper row is showing you appearing to be an esotropia. It appears because of telecanthus and epicanthic folds which are covering the nasal side of the conjunctiva. The second row is showing you another pseudoesotropia because of a large palpebral aperture, the uriblephrons, mrignani. No, girls may like to be mrignanis but not having a look of squint. The third row is showing you a pseudoexotropia, which may be a look of having an exotropia like I showed you earlier. How do we do that? We can do a simple cover test. You may use your thumb and see if the eye is moving, then we are sure that yes, it is a true squint. So you don't require too many sophisticated equipments. The most sophisticated equipment in strabismus is between our 2 ears. So, and then we have to give with proper glasses. And if we have done full correction and still we have an esotropia with the accommodative target, it means it requires bifocals. Prism cover test, not Hirschberg's, is what we will be advocating. Then when we are putting prisms, be careful. When you add prisms on prisms, there will be an error. See this diagram. Here, 2 plus 2 is not 4, like that old movie, Do or Do, Panch. So there can be a problem if you add 2 plus 2 on the same. You have to split the prisms over the 2 eyes, and then you will get the more correct measurement. Other problem is if you have glasses, high-powered glasses, if you measure through them, it will induce prismatic effect. As you can see in these diagrams, these are there in the books also, you can see if there is a high plus lens, it acts like a prism, because for a squinting eye, esotropic, the plus lens is acting like a base out prism. So it will neutralize the ESO deviation. So you will measure less if there is an ESO deviation. Similarly, if there is a myopic person having a high myopic glasses, again your measurements will be wrong. So you need to use some nomograms or formulas which are given in the books to correct if you are using these glasses. How many muscles we have? Leaving apart the one which Dr. Feroz has taken away, the LPS. How many extraocular muscles in each eye you have? 6. And if we have 2 eyes, we have 12 extraocular muscles. I generally say just like our zodiac sign, we have 12 houses and 9 planets doing mischief. Here it's 9 houses and 12 extraocular muscles doing the mischief. And we need to set them, just like grahon ko shant karte hain. In zodiac, we have to do these extraocular muscles, shanti. So this can create in different houses, different deviations. So you have to be careful when you are measuring. In the same person, you may have in the primary position an exo becoming worse in up gaze and becoming less in down gaze. So, and then on looking on the side, there is coming up a vertical squint. So you need to see in all the 9 houses what is happening, do a cover test in all the 9 houses and find out what are your observations. It's an esotropia, exotropia, hypertropia, hypotropia, or another thing which we are not seeing on this plano, that is the torsional deviation which may be there, like when we see in the fundus. Now what do you see? The fovea is much below the horizontal line passing through the lower pole of the disc, and this indicates it's an extorsion. EXTORSION, not with T. Some people say it with T. That happens in Uttar Pradesh and Bihar, extortion. We are only talking of the one with S, extortion. So that is what is you have to see that. And the other picture is showing you the fovea is much higher. That is an intorsion. So just by looking at the fundus you can see, and you can measure it with the help of the protractor on the pictures or the indirect ophthalmoscopy. Now when we are looking in the up and down gazes, what do you see in this girl? Eyes are straight in the primary position. It becomes exo in the up gaze and eso in the down gaze. In the same person, you may have a eso deviation in down gaze and exo deviation in up gaze. Why? Because it's a V pattern. It's a pure V pattern. Ortho in the primary position. And why is it there? If you see the side gazes, you will get the answer. There is an inferior oblique overaction in both the eyes. The eye in adduction is hypertropic. So we say over elevation in adduction. So this indicates there is an inferior oblique overaction, and if you can find out, then you can just treat the inferior obliques and you will get the correction. The eyes will remain ortho in all the gazes, even the vertical deviation will be corrected. So V pattern. How do we have to see? We have to just pan the eyes from down and up, and we can see that there is a V pattern. If it is more than 15 prisms between the positions of 35 degrees down and 25 degrees up, we call it significant V pattern. And whenever there is a V pattern, look for inferior oblique overaction. Similarly, there may be an A pattern. Now in this case, what do you see? The exo is more in down gaze and less in up gaze, or the eso it's becoming in the up gaze, and so it's an A pattern, esotropia. And for esotropias, you will look for superior oblique overaction. And how do we see that? In primary position, in 25 degrees up and 25 or rather 35 degrees down. 35 degrees, why? Because down gaze is more important. Many people who will have A pattern will have difficulty in walking downstairs. So whenever you have this, you look for overacting obliques. Whenever V pattern, which one will you see? Inferior oblique overaction. If there is an A pattern, you will look for superior oblique overaction. But it is not a must that all V patterns will have inferior oblique overaction and all A patterns will have superior oblique overaction. So we will have to see, and like in this case, what do you see? There is a V pattern, there is an inferior oblique overaction. Why do we say that? Because the inferior limbus is much higher, not by the coverage of the cornea. You should see the placement of the limbus. The inferior limbus is much higher in the adducting eye on either side. So this is an inferior oblique overaction, or we can call it over elevation in adduction. We can do a cover test to confirm. So whenever in doubt, do a cover test. The eye will come down and you will know for sure this is an inferior oblique overaction. But there may be a case in which there is V pattern and without inferior oblique overaction. So there may be 10% of cases with V pattern without inferior oblique overaction. There may be asymmetry also, and you can also measure them by the angle they make. Similarly, for superior oblique overactions, with and without may be there, so you look for it. So how much surgery should I do? It will depend upon the horizontal surgery I will do on the basis of the primary position deviation. In the primary position, whatever is the deviation, that is what I will plan for the horizontal muscles. And for the V pattern, I would have to do something else. What? If there are overacting inferior obliques, I will add the weakening of the inferior obliques. That will collapse the V or A pattern. If there are no significant overacting obliques, then I will shift the horizontal recti up or down, and that will correct my case. The other thing which you have to see is for near and for distance fixation, the deviations can be different. It may be an esotropia, it may be a basic type, means both distance and near fixation, you have the same measurements. Or it may be a convergence excess esotropia, more esotropia for near fixation. Or it may be a divergence insufficiency, means that there is more esotropia for distance fixation. When do we say it's significant? More than 10 prism difference. Okay? For exo again, we will have a basic type, a divergence excess exotropia, and a convergence insufficiency type of exotropia. So look for that. Like in this case, you can see here the near, the deviation exo is much less. For distance in the upper row, you can see the deviation is more, and it is not just breaking up of squint, because on Spielmann occluder for near again there is lesser deviation. So convergence insufficiency type of exotropia is another example here. You can see the exotropia is more for near fixation. We have to tackle them differently. For convergence excess, we may do a Farden operation. For a distance excess, divergence excess, we may do a combined resection and recession of the same lateral rectus. This is the newest technology, muscle technique that we are talking about that can be done. How much surgery? Yes, there are nomograms which you can use and change as per your surgical technique. The safe limits for different ages are different because the child's eye is much smaller. For an infant, 5.5 may be too much. For medial rectus and for lateral rectus, 6.5. But for adults, we may take it 0.5 more for these, and for lateral rectus up to 8 millimeters. These are showing you the example of shifting up or down. And this is showing you the sum of the instruments that we'll use and the techniques that we have. You all know recession, conventional, or it may be an adjustable recession hang-back approach. Or the strengthening procedures are the resection. What is the difference between a resection and recession? Anybody? A recession, you are disinserting the muscle and reinserting it closer to the origin. So it becomes a lax muscle. A lax muscle is an inefficient muscle, just like a lax student, right? And a taut student, T-A-U-G-H-T, becomes like a taut muscle, T-A-U-T. And a taut muscle is a more efficient muscle. Over the length tension curve, the muscle will become more efficient if you make it tighter. So a resection will increase the efficiency of the muscle. So let's see. It's not moving. Yeah. Can be. So we are sitting on the side so that we can see the muscle. What we are doing now is passing an anchoring suture at the limbus. A simple suture has been passed at the limbus to hold the globe for the moment that we will make the incision in the conjunctiva, and then we can remove the suture. So 7 or 8 millimeters away from the limbus, a small nick is made. This is a fornix incision approach. And then in this subtenon space. So first conjunctiva and then subtenon space. You need to go in the subtenon space, and then you will find that the extraocular muscle is right in its sheath. And then you go in the reverse fashion with this Jamieson's hook, hugging against the sclera and hooking the muscle that you want to, the lateral rectus being hooked here, and the conjunctiva is covering it. After this, I have passed the second Green's hook, and now we have to expose the muscle that we want to operate. So by using the lens hook, graphase lens hook, I am just ensuring that the muscle comes into our exposed field. Now the intramuscular septum on either side will be cleared. So it's important that we are working such that there is no sheath disruption and the entire muscle is in our hook. That's another thing which you can see here, because when we are going to pass sutures, we will pass full thickness bites in the extraocular muscle so that there is no slippage. The intramuscular septum is cut and the check ligaments are also cut under direct view, and then we will disinsert this muscle, and as per our plan we will reinsert it. We are using 6-0 vicryl sutures for this. I think for the video I will not go into the more. Recently now we have, instead of resection, we are doing plications, which is another newer technique which is there. But we have to remember what can go wrong. The intraoperative perils can be the wrong eye may be operated, operation may be on the wrong muscle, wrong operation, instead of recession, resection has been done. So you have to be all writing down in front of you what you are going to plan, otherwise these problems can be there. Then in the technique, hemorrhages, scleral perforation are avoidable things which you can take care of. Just like the training of a mosquito daughter, the mother trains that pull out Betty, you have hit an artery. So you have to be careful when you are doing it. Splitting of the recti is to be avoided, and so you will get to see all through, and the measurements you make it in a curved ruler when we have larger than 7 or 8 mm of recession or resection to be done. Whenever you hold the muscle insertion, it will be displaced artificially by you. So you have to be careful that you mark it from the other point which you have left undisturbed. And as I said, these slip muscles can be avoided if you have full thickness bites in the muscle. The post-operative problems can be nausea, vomiting, which is possible, and the infection should be avoided by pure asepsis. Anterior segment ischemia is a risk. Whenever you have more than 2 horizontal recti operated, then you will have a risk of anterior segment ischemia, because the vertical recti have no long posterior ciliary arteries. Horizontals have long posterior ciliary artery. Whenever you add a vertical, you are going to compromise the vascular supply of the anterior segment. So you may do something like a vessel sparing or other techniques which may be done. Adjustable surgery is another thing which you may do for more desirable results, and you can adjust it 5 to 6 hours after surgery to ensure that the correction is what you have wanted. I think now the obliques is the other thing which you have to remember. There can be, because of a cranial dysostosis, there can be a desagittalization of the superior oblique, which even in a normal superior oblique will make it weak and so present like a superior oblique palsy. So inferior oblique recession can be done for such cases, and when you do a total anterior positioning, this is how the inferior oblique is reinserted in front of the inferior rectus. It works like an anti-elevator. Another technique is the anterior nasal transposition, which can be done. So this is a sort of summary of the various procedures on the inferior oblique that we can do. I won't go into the video. These are all there on the YouTube on my site. If you want to see horizontal or vertical these inferior oblique surgeries, you can see on the YouTube, and you can correct the torsion by doing your surgery. So this girl who has been straightened. Similarly, the superior obliques, you have a list of possibility weakening procedures that you can do. So these are there in the books, you can see. But remember, what we need to do is to find out how much is the overaction, mild, moderate or severe, and accordingly we will do the weakening procedure. So this is a child having an A pattern exotropia with bilateral superior oblique overaction, and after surgery he is straightened. I think since our time is up, I will just wind up my talk. So we are now on the targeted strabismus surgery. We can do even in complex problems. We have to be a squintellectual, I say generally, and we can do this. And what I need your help is that each and every child should maintain and restore the stereopsis. We need to spread sight and happiness for kids the world across, maintaining the stereopsis and restoring the loss. Thank you all.
Thank you very much, sir, for an excellent overview. It was a revision for me also a little bit. Do we have any questions from the audience? Any questions? So I have a question for you. So often the difficulty that we face is the weak Bell's phenomenon, and taking a decision to do a ptosis surgery, whether to undercorrect in these situations. Is there a procedure where we actually can improve the Bell's phenomenon in these cases?
Yeah, many a times when it's a monocular elevation deficit, not a third nerve palsy, then we can use the horizontal recti, do a NAPS procedure. That is one thing. Nowadays we can do a modified Nishidas. That means without disinserting the horizontal recti, we can use the force of the horizontal recti by using non-absorbable sutures, the modified Nishida for NAPS. So
and we can actually expect a complete reversal of.
Yeah, it is very effective.
Okay.
But the problem comes up in third nerve palsies when even the horizontal recti are not functional. So that is an issue which we have to tackle it more difficult.
Okay.
Now
Thank you very
I think,
much.
yeah. So I think since Dr. Santosh is still not here, he'll come later. So we can have the next speaker, and we have Dr. Vishali Gupta from Chandigarh, Postgraduate Institute of Medical Education and Research, to tell us about uveitis. Dr. Vishali.
Thank you, sir. So I'll be talking about some interaction in uveitis. Now, before we start doing interaction, what is uveitis all about? Just imagine a jumbled up pile of books lying there, because there are 387 conditions which produce uveitis, and one can resemble other. So you want to find out what condition it is. It's like finding the right book. Now, if you have to go over this pile, maybe by the end of it, you will be able to find a book, but maybe you don't need the book by that time. So how would you organize yourself? The way you organize yourself is the books are catalogued. So when you have to reach the book, you just browse over a little rack which has about 10 or 12 books so that you can take out the book very promptly. So that is how the uveitis is. So how should you practice uveitis? Just do a very basic general history. No need to go into the sexual behaviors and homosexuality in all the patients of uveitis because they are not going to give you the history anyways in the beginning. So just ask very basic simple history. Do a comprehensive ocular examination to get an idea what you are dealing with. Go back with the specific questions and then examination. So how do we work it? And I'm going to interact with you all in the next cases to show you how quickly can you reach the diagnosis. The first and the foremost important step in uveitis is to be able to name the disease, and we are going to discuss how to name it. Once you name it, you mesh it. What are the known entities that fit into this name? And that makes it very simpler because then you investigate only those entities and not the entire gamut of investigations. So imagine and go through with me, just imagine you are sitting in a clinic, a patient walks in, and he complains of decreased vision in the right eye since 4 weeks. It is insidious onset. This is very important. You got to ask what is the onset. Patient has been using some topical steroids 4 times a day. He also has a red lesion involving the tip of the nose, and there is no other systemic disease. Now, what do you see? Any of you just shout. So what do you see on the cornea? Absolutely fine. So you see granulomatous form of keratic precipitates. Anytime you see the formed keratic precipitate, it is granulomatous uveitis, okay? So you also look at the pressure. Pressure is 8 millimeter. It is very important to look at the fundus because it could be a part of pan-uveitis and not only anterior uveitis. There is just 1+ vitreous cells, which means it is predominantly anterior uveitis. So what do you have now? This is what I said, you have to name the disease. So how would you name it? 40-year-old man, unilateral, insidious, granulomatous anterior uveitis with nasal redness, okay? Now try to mesh the diseases that you know of into this name. And if you think about it, there are not many diseases you can fit into. You won't think of SLEs or JIAs or other things because it is granulomatous form. So what would you think of? It could be TB or it could be sarcoid. And very important these days, the patients that we have on rise are the viral anterior uveitis. So it could be either of the 3. So within 5 minutes of examining the patient, you have just 3 differential diagnoses which you want to rule out. So which one of the 3? So now you go back, talk to the patient with a very specific aim that you are talking about either of the 3 entities. Patient's corneal sensations are normal, IOP is 8. If it was viral, the IOP is elevated. So any patient of granulomatous uveitis with increased IOP, always think of viral because no other form of uveitis causes the raise in the IOP. Look for corneal sensations which would be reduced and look for transillumination. In this patient, they are absent. But he has a nasal rash. What could nasal rash be due to? What nasal rash makes you think of uveitis patient? Herpes, Hutchinson sign, no? So you look at what the lesion is. He has a plaque-like lesion. near the tip of the nose. So it doesn't look like viral. Two things which you always remember if you ever want to practice uveitis. Always let your ego go. Learn to say, I don't know, ask for help. And never ever make a diagnosis which you cannot revise next day, next week, next month, or maybe 20 years later, because uveitis will keep evolving. So like in our institution, the residents have a habit. They look at the file and they say, a known case of VKH. There is nothing like known case in uveitis. What we say today may be wrong tomorrow. So I do not understand what this is, so I need a rheumatologist to help me out. In the meantime, the viral is already out, so we are between TB and sarcoid, okay? So how would you differentiate? You just ask any history of TB in the family, any history of treatment in the past. He says he does feel weakness, fatigue, and breathless on exertion, but there is no history of exposure to tuberculosis, okay? So which investigations would you order? Anybody would like to volunteer? It's interactive session, come on. What investigations would you give? Montius, okay? Another principle in uveitis are probably every medical specialty is don't just order the test because you have read about it. Never ever order the test when you do not know what you are going to do when the result comes, either positive or negative, okay? So what will we do here? We will order a very simple basic PPD skin test or the Montius test, and you have a plan. You have a plan that if Montius test comes positive, I could think of tuberculosis. If it comes totally negative in the population like ours, which is exposed to BCG, it could be very strongly suggestive of sarcoidosis. Okay, so either ways it is important, so I'm ordering the Montius. You could order chest imaging and be very careful because on chest imaging, you are not looking for cavitary lesions. No, that is, you are not going to go to the pulmonologist or to radiologist and say, X-ray is normal or there is no evidence of TB. You are looking for exposure to TB, which is a Gons focus, some calcified nodes somewhere, But if there is a significant hilar lymphadenopathy, I'm thinking of sarcoidosis. Quantiferon TB Gold, I will not even order now. So in the meantime, it is also very important. You start the patient on topical steroids, cycloplegics, you know you need to consult for nasal lesion, and you call the patient after 72 hours with a very simple plan. If PPD is positive, if it is suggestive of TB, I will add ATT. If it is not suggestive, I will see what I can do for sarcoidosis, okay? So let's see how it evolves. Patient comes back to you after 72 hours. Montius is negative, and you see these hilar nodes. What do you think it is? Shout. TB or sarcoid? Sarcoidosis, wonderful. So that is how, you have not really done much. You have just seen the patient, ordered two very, very inexpensive investigations, and you have already reached a diagnosis of systemic sarcoidosis. Isn't that wonderful? But you still don't know what the thing was on the nose. So my rheumatologist says it is something called lupus pernio involving the tip of the nose, which is very classic about sarcoidosis, okay? So we are almost nearly there, but whenever we talk of sarcoidosis, we like to have the biopsy. But if we look from patient's point of view, within 72 hours, his vision is improved because you are giving treatment, anterior chamber inflammation is reduced, and you are nearly there with the diagnosis of systemic sarcoidosis. What next? As I said, if you think of sarcoidosis, you need biopsy to confirm. but you have two sides now. You have the lymph nodes beautifully seen on X-ray, and you have a skin. Which one would you prefer? Skin, because the basic principle is first do no harm. So whenever you are thinking of the patient, you choose the one which is least invasive, and in this case it is skin. So here you go. This is the skin biopsy that confirms the sarcoid granulomas, which are non-necrotizing compared to necrotizing granulomas of tuberculosis. So you just made the diagnosis of systemic sarcoidosis and prevented this patient from going into the interstitial disease because you were smart enough to pick it up. So it doesn't require very hi-fi investigations. It just requires the art of application of medicine, which unfortunately we forget in the branch of ophthalmology. So what happens 2 weeks later? Not only have you taken care of his eye, you have also taken care of his nose and of course of his lungs. So the take-home message is, don't clutter your mind, just go systematic, because systematic approach is going to save time, efforts, as well as the money. Because you sitting in the tertiary care referral institute, you see patients carrying huge file, from patient to, from doctor to doctor and investigation to investigation, but none of those investigations are decisive. So don't do this to your patients and to yourself. The second mistake which we all make is we are somehow used to of looking at the eye. Sometimes we even forget that it is a complete patient who's walked up to us, and it's not only the eye. So I will give you an example. This again is an 8-year-old girl who comes with the inflammation, and you see the capes. These capes look like exactly the same I showed you in the previous case, where I said it was granulomatous anterior uveitis. But I also said always look at the fundus before you name the disease. Now this is the fundus. It shows a huge amount of exudation, vasculitis, exudative retinal detachment, and this patient was diagnosed, she is actually from this city only, so she had been to a lot of places and was diagnosed Coats disease, vasculitis, retinoblastoma, you name it, and the label was there for this patient. So what do we do? First is, if it is Coats disease, it should show some aneurysmal dilation. And how can I pick up those aneurysmal dilation? By simply doing a fluorescein angiogram. So you do a fluorescein angiogram. This is just to show you the left eye was normal. Now look at the fluorescein. This shows the presence of capillary leak throughout, and there is some disc hyperemia, and inferiorly it was dark because there is exudative detachment. But I'm not seeing those lighted bulb or those aneurysmal dilation that I would see in Coats disease. So if there is not so much dilation, how do I have a mound of exudates there? In the late phase, there is a diffuse leak. It means she does have vasculitis, but she doesn't have Coats disease. So what possibly it could be? Left eye is absolutely normal. So next step, unilateral retinal vasculitis, young girl. This is the name for my disease, Coats-like response, what it could be. That is what I told you, that first you do the examination and then do the general physical examination. You do the general physical examination, the child is very different looking, and we have the permissions of her parents to show the pictures. So the external examination, when you look, there is a right-sided hemifacial atrophy, and there is also zygomatic bony prominence that I will show you, and there is atrophic periocular pack. Now you see, this is what I mean by zygomatic prominence. And the father quickly takes out the previous picture and says, both the things have been going together, like the problem in the eye and the progressive atrophy. He says, my daughter was normal It's just last 1-2 years that her face is looking like this. I honestly did not know what we were dealing with till we got into it, and it is something called Parry-Romberg syndrome. I think my chairs here would know about it more than me. But anyways, this is something that shows reduced subcutaneous mass around the right eyeball, and this is confirmed on CT. That's not the point. This is capillaroscopy, and this is of course published now. But the moral of the story is the management changes. Instead of just managing your uveitis, our codes are doing lasers, are doing whatever you would like to do, here your aim also becomes whether you are going to prevent the progression of the disease. So the patient is shifted onto biologics and of course plan for surgical management with the bone and fat graft. So the take-home message is, please look at the patient as a whole and not only at the eye. And I think I have time to discuss just one more this, which is actually opposite of what I have shown, that sometimes phenotype in the eye may not be related to disease that the patient has. This is a 23-year-old male who comes to us with sudden and progressive decreased vision in both eyes. It's a very interesting patient. Patient was a known case of IgG4 related disease, and the differential diagnosis was something fancy, SAPHO. I will not go into details, but both of them are autoimmune diseases. So patient comes, he's carrying this OCT scan which was done a few days before, and he says, I have sudden decreased vision in the right eye. OCT looks kind of not something which at least I have ever seen typical of anything. This is what the fundus looks like. You know, there are some whitish lesions at the level of the outer retina, and there is some funny linear lesion here. And this is the left eye, and he's just a young boy who's counting fingers in both the eyes. He has IgG4. So my first thing was, oh, it is IgG4 related disease because patient is a known patient of IgG4. So I kind of promptly admitted the patient, talked to pediatrician, planned for IV methylpred, because that is what we do in uveitis, and that's what everybody thinks, that uveitis people are synonymous with steroids, which unfortunately is not true. Now look at the autofluorescence. Look at these linear. Look in the left eye, something very different. This is not what choroiditis looks like. And this was the giveaway sign. This is kind of a pillar in the outer retina, and this is growing like this. So even though patient had IgG4, this does not fit into the systemic phenotype. So it's not only you look at the patient, you also look at the eye. So don't start pushing steroids because patient has an autoimmune disease. Look at this. So to cut the story short, the fluorescent was not typical of anything, neither was the ICG, and what we had missed was this typical OCT. This OCT is very highly suggestive of laser-induced maculopathy. So don't miss it, because there are a lot of children now with the toys, with the pointers, with the laser pointers going around. And when we asked this patient, he says, yes, he had been to Goa, bought a Chinese laser, and was, they were playing and throwing it into each other's eyes. So, and this is the literature which shows a similar case. You can see this. This is what, if you don't understand it, ask for help. And in my patient, a dear friend, Bailey Frond, helped me in reaching the diagnosis. So look at these linear scars. So Bailey had reported it earlier. This is laser-induced maculopathy. So of course, this is what patient told me, what he had bought. So you may see more of these patients. So we have published now in retina, but that's not the point. The point is, when you are practicing uveitis, please be very careful with what you are dealing with for two things: to reach the systemic diagnosis Number 2, to prevent the morbidity as well as mortality. I don't have the time, otherwise I would have taken you through lymphomas and all that more dangerous stuff, how you can diagnose it. And sometimes, like in this laser-induced maculopathy cases, you can actually prevent the starting of immunosuppression, because many a times you realize patient with Fuchs disease, and Fuchs is known to have some vitritis, they are on steroids, they are on short of biologics, they are on everything, because we don't understand the phenotype. So that's all I have to say, and you're welcome to ask any questions.
Thank you, Dr. Vishali. So now the house is open for questions, as we don't have the next speaker yet coming for that time. If there are any questions from Dr. Vishali or Dr. Feroz or from me, you're welcome. So if anything that is not clear or you would like any other clarification, please raise your hands and question.
You won't get this chance. Again, you have like the doins, like Dr. Vaishali Gupta, Dr. Pradeep Sharma here. No questions? Either you understood everything or things
That's
have flown beyond
Or it
your
was
head.
like post-lunch siesta. Slept through. It's like that joke, no, that person said that how was my talk, a speaker asked, and the person got up, he said that the first half was a little problematic. Why? There was some disturbance I could not get through, and the second half you could understand, but then I slept through. So
Thank
hope
you.
you had a good sleep through that. Any questions, please? So we have an enlightened audience. We really feel good. Is there
Any interaction? We're just waiting for Dr. Santosh Unavar. The session is till 5 p.m. So you actually have time, 5 more minutes to discuss. We have some bright students sitting in the last bench. No questions?
Or comments?
Yes, you.
Maybe if
Not
you have.
Srinivas. Next to you. Any comments?
Okay, sure, Srinivas.
So meshing is very important, okay? Because what you label on your paper during a diagnosis in uveitis is extremely important. You label it as, is it acute, is it chronic, is it anterior, is it posterior, is it pan uveitis, so that you come to a provisional diagnosis. And like ma'am said, it's targeted approach which is very important. Otherwise you will be ordering all sorts of tests, and when the results come in, you are totally confused as what to do and what not to do. So it was a very, very important and extremely good talk. I've not heard her talk before, but I've heard about uveitis talks a lot, but this was very well done. Thank you, ma'am.
Ma'am, I have something to ask you. What would you like to advise the students? Like, if a case of uveitis comes, how would an examiner want them to approach it?
Don't jump into all the investigations at once. First, do a rehearsal in your mind that what you are seeing. For example, if you are seeing a young girl, 6-year-old, band-shaped keratopathy, complicated cataract, so what it could be, the first thing that should come to your mind is loud. I'm getting old. JIA, isn't that? Nothing else comes to your mind. So when you have seen it, you have put down like those telegraphic language, that is naming. So you say 6-year-old, bilateral, chronic anterior uveitis, BSK, complicated cataract, and maybe if you are seen at the advanced stage, there is hypotony. Now it's a non-granulomatous uveitis, so there are not many things which will fit into it. The first thing you will put it is a JIA, and the only investigation you would need is ANA. So no need to get Monteus and everything for every patient. Just do whatever is required for that patient. So that was just an example. So if you are able to name it well, mesh it well, you would automatically get very few investigations, and it would be very useful to reach the diagnosis. And secondly, you have to be aggressive in uveitis management. Don't be scared, like you see the first patient, granulomatous anterior uveitis with those KPs, and somebody is given 4 times whatever steroid drops. That's a joke, you know. So you have to have zero tolerance for inflammation in the eye. And if you decide it is inflammation and it requires treatment, then it requires treatment. Then there is nothing like steroids will raise the pressure or cause the cataract. There is nothing like it. Then be aggressive about it. So that is the second message I would like to give. And third is, if you don't understand, then of course seek for help. If something you don't understand, you want rheumatologists, you want radiologists, but don't go away with the impression that uveitis is all about molecular biologies and PET scans and all those. We do talk of that in the meeting, but that is only for very select, challenging patients. So the normal uveitis, majority of it should be handled by the comprehensive ophthalmologist, because it does not require too much of knowledge. I mean, it requires knowledge, not too much of lab backup. Yeah.
On ocular oncology perspective, there is some principle that we believe. Extremes of age, be it a child or an old man, there are few things that we keep in mind. In a child,
We do also.
Yes, yeah, retinoblastoma and leukemia, or even ciliary body medulloepithelioma in a child. And if it's an extreme old age patient, lymphoma is something that we
Lymphomas.
always keep in mind. So this is like we always follow this principle in ocular oncology.
We do in uveitis also. The autoimmunity occurs in the middle age. In children, there are not too many autoimmune diseases except JIAs and now BLAUs and all that. Autoimmune system, I think, gets tired after the age of 50. So any patient coming to you for the first time in the later part of the life without any history of previous episodes of uveitis, always think about masquerade syndromes. The second is, look at the type of the cells. If you think those cells are bigger than the WBCs, there are no synecdoche formation, or there are something which is not usual. Like my next patient was actually lymphoma, which was a very interesting patient, but I think I ran out of time. But if you feel anything unusual, then you start thinking of masquerades. So when do you think of masquerades? One is extremes of age. Second is patient is not responding the way you want the patient to respond. So you have seen uveitis or vitritis, you have started on therapy and patient is not responding, or there are too many recurrences, or there is something which just doesn't feel right. So those are the kind of the patients you have to rule out masquerades. And lymphoma is somehow on rise. Like I see one patient every week of primary vitreoretinal lymphoma. I don't know whether I'm attracting them or I'm diagnosing them, but it's really even in the younger age group, like 30s, 40s. So that thing of 60s, somehow it's changing for us. We are seeing a lot more lymphomas in the younger age group. Yeah.
Thank you very much. So I have this question for Dr. Pradeep Sharma now. I was always scared of strabismus as a postgraduate. So sir, do you expect a PG to get an A pattern or a V pattern for their practical exam?
No, it could be there. So any case of strabismus could be having an A and V pattern. So the examiners, when they may have allocated a case, they may not necessarily have seen. So you would have been examining it in more detail than the examiner sometimes. And any case may be having. So what you need to do is not to be disturbed or be scared of it. As I showed you, you just need to do an examination, an observation, panning the eyes from top to bottom and see what is happening to the eyes. This is one of the simplest things. You just need to see what is happening. Is the exo becoming more or becoming less, and in which gaze? the next step would be to see how much. So a little bit of V pattern may be there normal. So if it is more than 15 prisms between the top and bottom, then we say it's a significant V pattern. Similarly for A pattern, if it is becoming more in and more exo downwards, then it's an A pattern. So it's as simple as ABCD, alphabetic syndromes. So that's nothing very scary
So
about
makes it easy.
So that is what you need to see, and once you have that, then you look for the significance of it. If you have an A or V pattern, as I said, if there is a V pattern, what will you suspect? Inferior oblique. So for inferior oblique, which gaze have you to see? So in adduction, you will see what is happening. Hypertropia coming up in adduction, or over elevation in adduction. So just look for that. And as I said, don't go by how much cornea is covered. Look for the inferior limbus. For inferior oblique, look for the inferior limbus. For superior obliques, superior limbus. See the level of the superior limbus in adduction. So if they are at different levels, then you can do a cover test and confirm. So as simple as doing a cover test is the easiest thing that you can do. So you'll never go wrong whether there is an A and V pattern and there is an associated superior or inferior oblique overreaction. By the way, if you are scared of strabismus, the examiner may have been as scared.
I was always scared. How many final years are here? Final year PGs? Yes, final year PG, okay. Are you comfortable using prisms? Speak up, no? Just ask him, he's right here. Ask your doubts. Are you comfortable? Yes? Second year PGs? How many? The final year is comfortable. Yeah? You are postgraduates, both of you? Postgraduates, yeah. So do you work up strabismus cases in your college? So what all are the things that you do? Share it with everyone. Okay.
Okay. So basically PBCT is nothing but doing a cover test with the prisms interposed in between. So whatever you are getting the information on a cover test, you are then quantifying it with the prism in between. So if you had seen an exo, which type of prism will you put? If there is an exotropia, you will start with which type of prism? Base in, base out? Base in, very good. So base in, the apex always towards the deviation. Simple as that. So you put base in prism and keep on increasing till you get a neutralization of the deviation that you had seen. So simple. And then you have to do in up and down gazes to confirm A and V patterns. So it's not as scary as it is made out to be. Yes, it is little more work. Many of the other investigations are more costlier and less yielding than probably these tests which can be done.
Any more questions?
Anything that you have come up, you feel free, because we have free time now.
Yeah, this
and
is
we
just a
can
discussion,
make
an
good of it.
informal discussion, not
So-
even a formal discussion.
So visual acuity testing in children, which tests are you aware of? Let's go a little different. What we have not covered. If you have to assess visual acuity in a child, how do you do? Any of the final years? Can you take the mic and tell?
Yeah, just one final year and everything is going to come to you. Come, it's a
Okay.
practice for your exam also. Come.
Sir, if it's an infant, I would first check the child is fixing and the fixation is central, steady and maintaining.
Good.
And if it's a grown-up child, I would like to do with K-test, Allen picture test, card test, HOTV test.
So which is the most validated or acceptable picture test? Picture or symbol test?
Allen.
The LIA symbols, okay? They are the most standardized, the LIA symbols. So they are to be, which are like a house, an apple or a circle. So these are simple symbols which can be appreciated by a child. And if a child is not able to verbalize it, what do you do? It's one thing is that you ask, is it a house or an apple? That is an older child, 3+ will say. If it is a younger child, what do you do? It's a picture matching. So around 3 years, if you can't verbalize, you can give an object similar and then he can say which is similar. So that a child can do, okay? So these are things. There are some tests which are direction identification tests. Can you, anybody name some of the direction identification tests? The second years or anybody else? For vision testing, even in illiterate adults, not just children, it may be illiterates which we may have sometimes. Huh? So one is E, which is the direction identification. The Landolt C. Any others? A quiz question. Any others you know? Broken cartwheel also is like Landolt C. Okay. Any other?
Sir, आपने कुछ बोला?
Huh?
Dots.
Dots means? I didn't get it. How do you assess vision with dot? I didn't get it. You may use the hand. Again, hand is used for the Sjogren's hand test. That is also available. Then there are arrows which may be used, and so there are different types of direction identification tests also which can be used in some charts. You may get them. So even if a person is illiterate, and in India it's possible, you may be in a part of country and the person is of a different language speaking, so he may not understand that language, so you have to resort to these direction identification tests. Anybody knows about meridional amblyopia? Okay, now this is a little higher level question. Huh? So people who have high astigmatism may have amblyopia, but how do you diagnose that? Because a person may be having a high astigmatism, it's not necessary that he will have amblyopia. Maybe the astigmatism came up much later. No, a keratoconus may have developed later, so he may have an astigmatism but no amblyopia. So how do you know that he has meridional amblyopia?
Yes, please speak up.
Huh? You correct the astigmatism. Okay, so how do you correct the astigmatism? And what he's saying is right. So on one is that you will have to do the full refractive correction, which is a laborious thing. But on the spot, what can you do immediately?
He says retinoscopy.
So you can use a slit. A slit will, just like a pinhole is used to know if there is a refractive correction which is improving or not. So you can use a slit which can do for astigmatism, and in that particular axis only it will work. So right. So that is there. And the other thing which you will know is from his reading of the chart, he will miss one set of letters which are in horizontal identification versus the vertical identification. So he may be giving like 636 on some letters but 612 on the other letters, because he is able to see all the horizontal separations but not the vertical ones. So that's another clinical way of knowing that a person may be having a meridional amblyopia. Okay?
Yes, please.
Yes. Yeah. Right. Okay. So what she is raising a point probably is that when you are doing a cover test, what happens if there is a poor vision in one eye? Because if you have covered the good eye, the eye with the poor vision is supposed to move in order to tell us that the eye was really squinting. But if it has no PL, for example, it will not move. So it doesn't mean that there is no true squint. So in cover test, we need to have three prerequisites. One is that the eye should be able to see, or fixation should be possible. Second, there should be ability to move. Other thing is, if there is a very strong, a paralyzed eye, it will not move. Even though it's a definite exo which you can see, you do a cover test, cover the good eye, the eye doesn't move. So it would not be correct to say that there is no exotropia in that case. Third is eccentric fixation. So 3 prerequisites you will have to see. So whenever you have a cover test and you see that there is an exo but it is not coming correct, then you have to look for, is the eye seeing, is the eye able to move, that you can check that with his own thumb you can ask him to move even if he has no vision. Because of proprioception he knows where his thumb is, so you can make his eye move and see for it. So these are very good questions that you should be able to distinguish. So if there is a unilateral squint, it may be because of a sensory exotropia, very poor vision. So it may not, on the cover test you may not get a corrective movement. Yeah, then the deviating eye will move. Yeah. No, the good eye is behind the cover, it will move out, yes. Then it should come back again. No, in alternating also it will come back again. The difference would be if there is a phoria and how good is the fusion. So suppose there is no fusion possible, you have broken intermittent divergent squint with very poor fusion, you have put a cover test, the eye has gone out, and then when you remove the cover it stays out. This means there is a very poor fusion. Normally if there is a good fusion or there is an exophoria, there will be a very good rebound, the eye will come back. So it also tells us how good or bad is the fusion. So let's be very clear. Intermittent divergent squint, when we use the term, we are meaning that the eye has the ability to fuse back. When we say alternating exotropia, generally we use this term only when there is no fusion. So we would then use the term intermittent divergent squint manifest exotropia. If it is most of the time expressing out but only rarely having a movement, then it's a manifest exotropia, but it's an IDS, intermittent divergent squint. Whereas a truly alternating exotropia, there would not be any ability of fusion. All the time it will be always alternating. So that's why we call it alternating exotropias. Good.
Great. Any questions on ptosis
So
and
feel
orbital
free.
tumors?
I mean, there may be doubts. Sometimes we take it for granted, and sometimes you may feel that, okay, where should I ask? You are free to ask. Please.
Any questions on ptosis? Orbital tumors?
Yeah. Okay. First you.
Sir, there are so many
Yeah.
there are so many squint surgeries, no sir. For example, if there is an LR palsy, we will resect to make it strengthen. If there is an overaction, we will recess it. So sometimes you will do resect and recess. So is there any rationale to remember or to know how to?
Okay. The simple rule is that if there is, let's say, an exotropia, then we need to weaken the lateral rectus so that the eye can come into the center, right? And so weaken the lateral rectus and strengthen the medial rectus. That's simple. For weakening you will do recessions. For strengthening you will do a resection or a plication. What is the difference between resection and plication? Anyone?
We are not cutting, we are just tightening the muscle.
So we are double breasting. We are not disinserting and cutting. So the advantage is the intravascular supply is not disturbed and you are still strengthening it. So these are the two common procedures, but these are only possible, let's say, in sixth nerve palsy if you are talking about, and there is some lateral rectus action, then you can resect the lateral rectus and make it stronger. But if it's totally paralyzed, it's like whipping a dead horse. You wouldn't like to whip a dead horse to make it alive. So in that case you have to find out another avenue. So here what we'll do is, we can't do improvement by lateral rectus resection. In such cases we will use transpositions. We'll use the other adjoining muscles to give us this abduction which is missing. Yes? Can you use the mic? Probably maybe all can hear. Yeah, she can give you.
So cases of large angle exophoria, basically they are intermittent XT only, but usually usually they have good fusion, like when they can make an attempt to fuse. So do you advise surgery in those cases?
Okay. So the question is, if it is a intermittent divergent squint, but it's large angle,
Yeah.
right? Now basically it depends upon his ability to cope up. So how good is the fusion and how good or bad are his symptoms. If he is a person having, let's say, 55 prisms of exo, but he is fusing,
Yes.
but he is complaining of that he is having headaches when he
Yes,
does reading
yes,
and all.
yeah.
So this is an asthenopia or eye strain which we need to correct. So that requires surgery.
Okay.
The second symptom he may say is that he does fuse, but the objects become smaller, a micropsia, because he is using his accommodative ESO power to correct that exo. So he may fuse, but whenever he does that, he may usually, if you ask him, he'll say micropsia. Things become smaller to him.
Okay.
So then again, it's an indication, because this will lead to an eye strain because of overuse of accommodation.
Right.
So then again, indication is there.
Okay.
These people, if you test on the stereopsis, you'll find that they are already started to deteriorate in their stereopsis.
Okay.
So generally, otherwise we have been using the formula that how often the squint is manifesting.
Yeah, like Holmes grade.
More than 50% of the time, or we may use the Newcastle score,
Yeah, Newcastle.
that is based on that. So, but if suppose the child is coming there and you want to make an assessment, you can do also on the basis of the stereopsis.
Okay.
If his distance stereopsis is affected, or even the near, the distance gets affected first and the near also gets affected later on. So if they are being affected, means there is an indication for surgery.
Okay.
We want to restore that.
Thank you, sir.
And mind you, it's not the amount of deviation which is important. It's like the stress and the coping mechanism. To give an analogy, some people can take up lot of stress and cope up. The other people will break down on a minimal stress. So some people will have 15 prisms and they are having a more of manifestation, and the others may have 55 prisms and they are still having exophoria, as madam was saying. So it's possible. The deviation is not important. It is how much time the manifestation is happening, or how good or bad is the control. So good question. So sometimes there are very simple things that will make your things clear. So because of lack of time, probably we are not able to cover. But if that is being, I think we have taken up the time, and we thank all the presenters and all of you who have been patiently listening. And we move on to the next session. So the retina people will take over. Thank you.
Thank you very much.